डॉक्टर बेहरा, आपका ऑडियो प्रॉब्लम।
म्यूट है सबका।
Oh, sorry. Sorry.
Yeah.
Uh, Good afternoon, ladies and gentlemen. Welcome to this third series talk on allergy in collaboration with Clinics India. Professor Gulati, Professor Rajkumar, Dr. Anupam Agarwal, they are here to conduct this, session today. As you all know, allergic diseases or allergy are very common problems, but unfortunately, this problem is being ignored by many of us, except possibly bronchial asthma, which we do something, learn something, but the other types of allergy diseases are being neglected. If I can give you the 25-30% of the world population, including India, they suffer from one or other form of allergic diseases. To bring about this awareness and to spread the awareness about allergic diseases, the Indian College of Allergy, Asthma and Applied Immunology has started this series in collaboration of clinics, in collaboration with Clinics India, and we have also a weekly asthma chart in collaboration of the VP Chest Institute. And today, I know we have got the expert, Professor Gulati, a known figure in this country, an international figure, in fact. So he's going to talk to you about, allergic rhinitis. So you will have your queries, your questions, and he's going to, clarify many of these issues to all of us, and I am sure we'll have a great learning. So with these few words, now I'll invite Professor Rajkumar to start the session. He's going to moderate it, and then we'll have the Dr. Gulati's talk, and then he's going to answer some of your questions and queries. Now over to Professor Rajkumar.
Thank you, Professor Digambar Behra. Dr. Digambar Behra is the president of the Indian College of Allergy, Asthma and Immunology, and he is the Padma awardee, and he is the ex-professor and HOD of the Department of Pulmonary Medicine, PGI Chandigarh, and he has been the president of the other societies also. Thank you, sir. Thank you so much. And myself, Dr. Rajkumar, I am the director of the Vallabhbhai Patel Chess Institute, University of Delhi. And this program is basically on the behalf of Indian College of Allergy, Asthma and Immunology, and we do not have any disclosure. And this is the educational program of the Indian College of Allergy, Asthma and Immunology. As you heard, Professor Behra about the topic and everything. So I am going to introduce the speaker who is the stalwart in the subject, Dr. Achal Gulati. He is the president and the vice chancellor and the professor of excellence at the Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Dr. Achal Gulati, former president of the Ethic and the Medical Registration Board, National Medical Commission, and the additional Director General Health Services, Government of India. After graduating from the University of Delhi, did his postgraduate from the PGI Chandigarh. After working at Maulana Azad Medical College for more than 3 decades, he was instrumental in establishing a new medical college and the Dr. BSA Medical College, New Delhi, as its founder, director, principal, and later headed the Govind Ballabhai Pant Institute of Postgraduate Medical and the Research as a director. A fellow of the National Academy of the Medical Sciences, the Indian Academy of ENT and International Medical Science Academy. He has all-round variety of interests ranging from the professional excellence in the field of the head and the neck surgery and the endoscopic sinus surgery to the field of the medical education. He is the recipient of the numerous orations and the awards, including National Eminent Teacher of Excellence Award by the Government of India, Dr. Radhakrishnan National Award for the Eminence Teacher, and the State Award for the contribution in the field of the medicine, and Great Teaching Master Award, Times Research Medical Excellence Award in the healthcare, etc. A pioneer in the development of the OSEC model of the evaluation at the postgraduate examination level, a keen and a professional quiz master at the national and international level, a food and the travel critic writer also. He has over 95 publications, national and international, and contributed many chapters in the different textbooks. And he has developed basically many series on the examination technique, and has also produced a documentary film titled To Be or Not to Be, which is based on end of life issues. He has been invited as a visiting professor to deliver series of the guest lectures at the different parts of the country and internationally also, like Italy, USA, Kenya, and other best institutions in the world. He is presently a member of the board of the governors of the International Rhinological Society, the current president of Indian Society of Rhinoplasty, and the former president of the All India Rhinology. And recently, he has become the advisor in the medical sciences in the Meghalaya government. And he is going to talk sneeze and the wheeze, the inseparable twins. So over to Professor Achal Gulati, sir.
Thank you, Dr. Rajkumar. It's indeed a pleasure to be amongst everybody of you over here to talk about this love affair between the sneeze and the wheeze. ये एक ऐसा रिश्ता है कि हम तुम्हें जीने नहीं देंगे, वो हमें मरने नहीं देगा. If I sneeze, you will wheeze. If not today, then definitely tomorrow. So I will just share my screen, and then we can start on. Okay, so very good afternoon to all of you. I want you to focus on this particular scene which is being played in front of you. The expressions, what you see of the various people over here are something which, if you observe, you will notice what they actually are into for. If you see it in slow motion, what exactly is going on, eyes closed, deep breath inside, it's not yoga, mouth open, inhaled inside, deep inhalation, eyes further clenched, and then comes the blast of the sneeze, what you see and what you feel over your face at times when you are sitting in front of such individuals. Now this scene, if you imagine, somebody has a bout of sneezing which is happening. 5 sneezes, 10 sneezes, 20 sneezes continuously. You're sitting in an aircraft, and all this act of sneezing occurs with all the things which are coming out of the mouth flying all over. You can imagine the consequences and the hygiene about everything. And it is no wonder that the droplet infection forms one of the major sources of issues in today's disease process. The sneeze and the wheeze, the inseparable twins. This topic which is there is a part of the third module for the advances in tackling allergy and asthma, which is under the aegis of the Indian College of Allergy, Asthma and Applied Immunology. Before I start, there is nothing to declare as a conflict of interest for this particular topic as far as I am concerned. You see, an old song is being reminded to me for today's topic. It not only depicts the beauty of the song, but it also depicts the love affair between the sneeze and the wheeze. जहां भी तू जाएगी मैं वहां चला आऊंगा, तेरा पीछा ना छोड़ूंगा वीजिए, क्योंकि हमारा प्रिंसिपल है वन एयरवे वन डिजीज. वो सोनिया ने पीछा तो नहीं छोड़ा, but here over here in this principle of one airway one disease is what we are looking at from this topic. And what is the principle for this one airway one disease? What goes through the nose, through the mouth, through the oral cavity, through the throat, also goes through the trachea, the bronchi, the bronchioles, and the alveoli. So what starts as a story at one end continues further as the plot of the story till it ends in the climax. And that start of the story is what the inhaled. The continuation of the story, the plot of the story is the sneeze. And the end of the story, which is the, as the plot thickens, is what we end up in the wheeze. So, what are we looking at? We are looking at a long passage with the rooms on both the sides. What is this? The front door is your nose and the mouth. The doorways along the passage are the sinuses, the eustachian tube, etc. The hallway, which leads further down into the lungs, are the trachea and the bronchi, that is the hallway. And guarding this hallway is a healthy immune system. And this is supported by a very efficient housekeeping agency, which is the mucous membrane, the secretion, and the cilia. So if we just imagine this one housekeeping issue which comes across, a passage, both sides the rooms, sinuses, eustachian tube, continues inside, trachea, bronchi, alveoli, guarded by the immune system, protected by the mucous membrane, secretions, and the cilia. And the moral of the story over here, which will come, is any issue with any above the above areas or the agencies will lead to the sneeze and maybe followed by the wheeze. So that forms the principle for today's topic. So what is this topic? It is a topic, if I look at it as an ENT surgeon of allergic rhinitis, the first part of the sneeze which comes in, it has so many names. I can enumerate more than 30 names over here. Why are these 30 names over here? It is because it is an enigma. It is a topic which is there, everybody sees about it, but very few people understand why it is there, how it is there, and how we manage it. So all these are the different names of the allergic rhinitis as and when they occur. And when we have so many names, it shows our ignorance about the subject further down. So what is it? In today's time, the picture on the left depicts the Khari Bauli. That is the largest wholesale market for spices, grains, etc. in the country. So over there, we have so much of pollutants all over the spices which are there. We have so much of traffic. We have so much of pollution, not only human pollution, we have noise pollution, we have air pollution, we have everything that is there. And this results in an irritating mucous membrane. It is time consuming for everybody to pass through this market. It is a drainage on the resources because so much of the green energies havoc is created, and it creates so many health-related problems. The same way, if I look at my nasal traffic block, here I have a vehicular traffic block, there I have a nasal traffic block, my nose is obstructed. So what happens over there? Nose traffic block is also irritating, it is also time consuming, it is also drainage of resources, it also creates health-related problems. So if you see, my environment problems and my nose problems, both of them are related somewhere between the two. And what is the common factor? Both are common everyday problems, both are ignored but manageable problems, both lead to miseries in the everyday life. So, what happens this? This is what India's Delhi as the capital
the planet's
is.
most polluted city.
The pollution which goes on over here,
from coal-fired
with an air
power
index of
plants,
426,
dust,
which is hazardous,
burning,
we breathe
fuel,
in this every day.
Cars.
Now what happens when you breathe in every day?
Tiny toxic particles that quality
Goes inside my nose, my mouth. Remember those door we had said?
500.
Through the passages.
Last year's
Remember
average
those passages
unhealthy
which are the trachea into my alveoli.
By comparison, the worst
So what
Delhi, where
starts
weather
over here
conditions combine
as
to
the
hold
pollution
smog
over here
right
goes
overhead.
into my
It's considered
lungs,
so
and we
alarming,
talk
so
about pollution. We talk about environment, and this is what we end up in. What significance does this have? It has a great significance. During the COVID period, we learned a lot many things over here. We learned that if we have no vehicles, if we have a clear pollution-free area, if you're wearing a mask, all these issues are avoided because we saw the reduction in the allergic rhinitis, we saw the reduction in the bronchial asthma in this particular period. So what are the objectives for today's talk? The principle of the sneeze and the wheeze, understanding what the sneeze or the allergic rhinitis is, and how to recognize the sneeze issue, that is the allergic rhinitis, and how do we try to manage the thing. So the limit of relationship between the sneeze and the wheeze is what? Where did it start? Where did it finish? And what will it lead to? Neither me nor you have understood it completely, and we are all in the process of trying to understand how it goes about. The day we understand, we'll have a lot many more Nobel Prize winners in this field. So what does the word allergy actually mean? Allos and ergon, other, work. The inappropriate response of the body's immune system to normally harmless substances. You know, we normally feel that, ye kya hai, choti si to cheez hai, what will it harm me? It's normally harmless. But if you trouble it too much, then that thing also raises its head. ये तो तारीख गवाह है ना कि जब जब किसी को बहुत सताया गया, so he has hit back on that particular person. The same is what is happening over here. These so-called harmless things, the minute they sensitize the body, they create a problem situation, which is the allergens. That allergen is which is produced as the harmless thing. It was initially there. It got exposed once. It said, okay, fine, it's there. But then second exposure, when it happened, it said, ab nahi chhodunga main. And that allergen is the one which causes the triggering of the immune system, leading to the allergen and the allergic issue which come across. So how common is this allergy? Dr. Digambar in his opening said that about 25% of the population suffers for it. You see, 80% sufferers are below the age of 40, 19% between the 40 to 60. 250 million or 25%, like very correctly Dr. Digambar Vera said, our population suffers from allergy. That is 60 million, if you look at it, only 60 million suffer from cardiac problems, and compare it, how many people, 250 million from allergic issues. So cardiac problem, everyone is worried about. Allergic problem at 250 million, I'm not worried about too much, but the impact that it has is phenomenal. And 55% of these people, that is more than 25%, suffer from allergic rhinitis. Sneeze and wheeze combined together. So see, what are we going towards? We are going towards a situation which is an epidemic for asthma also, if I look at it. So in general, if I look at it, 13 to 14% of the population has allergic rhinitis, which translates into about so many millions of people. Costs, 800 to 1,000 crores rupees for drugs alone. Consultations, investigations, free treatment in government hospital, research and development, loss of man days. Can we imagine what is the cost of allergic rhinitis? These figures are mind-boggling. And abhi we have talked only about allergic rhinitis. Now we add to it asthma, the wheeze also. Because rishta to humko banana hai na, sneeze or wheeze ka. And when both of them marry together, you see the logarithmic increase in the cost of burden when it comes to this disease process. Males, females equal, less to the age of 4 or 5. 3 pollen seasons will pass approximately before we start having the manifestation of the issues. 10 to 15% young adults, and peak age at the age of 30. So if we look at it, what happens? We have, number one, the first is the family history. Add to that, the environment. Further add to that, the genetics. Add to that, the timing. So if we see all these things adding together, we have seen the slots are there, which are being filled up. But there are still so many slots which are vacant. We have the slot over here, which is vacant. We have slot over here, slot here, slot here. All these slots are vacant for what? They are meant for the further research, which keeps on adding, and we keep on filling the slots. But every research that we add will still have more slots for our research avenues to be open. So if we look at it, if we have both the parents who are sibling, the incidence goes up. Genetic, where am I staying? How am I growing up? Where am I living? What is my pollution level? All these things make the difference for my primary disease. So if I have to produce an allergic infant, ideal, I'm a producer. So if I have to produce an ideal allergic infant, the mother's milk, bottle fed, early weaning, little contact with other young children, warm humidity, atopic siblings, a male, firstborn, cesarean section, atopic parents, when all of them are mixed together and produce a baby, it is going to be an ideal designer baby. It is what is going to be a copybook style of a baby. So if we classify them, we would have either seasonal or perennial, intermittent symptoms or chronic and persistent symptom. And if I see the ARIA guidelines, that is the allergic rhinitis and its impact on asthma guidelines, I have intermittent, persistent, mild, moderate to severe. I can mix and match any one of these 4 to make it intermittent, moderately severe, persistently mild, moderately severe, mild. So whatever it is, I can mix and match my various things to cause the classification for the various types of asthma. So if I have less than 4 days a week, or for less than 4 weeks, I would put it as intermittent. But more than 4 days per week and more than 4 weeks, it will be a persistent. What is mild? Normal sleep activity, no impairment of daily activities, normal work, normal school, no troublesome symptoms. But the issues are there. That will be a mild thing. But if I increase one or more symptoms and include abnormal sleep, impairment of my daily activities, abnormal work, school, troublesome symptoms, I would classify them as moderate to severe depending on the intensity. And I can mix and match everything to create my type of allergic rhinitis which I have. What causes it? It could be inhaled. It could be ingested. Inhalation, pollen, grasses, weeds, house dust, dust mite, animal dander, feathers, etc. You name it, and I can inhale anything. If the size is smaller than my oral cavity, if the size is smaller than my nasal cavity, I can inhale anything which comes across. And ingestion, wheat, eggs, milk, nuts, anything, food allergy, everything can contribute to it. So if I look at the opening line of Samson Wright, which says that one can be allergic to anything under the sun, including the sun itself, is absolutely a correct line to state what all and how much we can be allergic to. Exposure. Now, what is exposure? Exposure could have different concoctions. A photographer would have a different exposure. A lady in a bar would have a different value for exposure. Or a surgeon would have a different value for exposure, how much the neck is exposed during surgery. Or an immunologist would have what allergen is exposed and what is its effect. So basically, I have the first exposure, I have the second exposure. The first exposure, chalo maaf kar diya, let me be sensitized. Second exposure, I'll come across with something more severe. Let me lead to the release of mediators and have these various other effects which will present with my asthma or allergic rhinitis. So when I look at the allergic reaction, I look at sensitization, I look at IgE production, the arming of the mast cells, release of the mediators, and going down to the clinical effect. That's how the cascade will work down to create the symptoms. So mechanism, I could have irritation-free, the irritation of the free nerve endings. I could have itching and sneezing. I could have, will lead to, an increase in the mucus production will lead to rhinorrhea. Vasodilation would lead to congestion, and increased vascular permeability would lead to edema. So if you see, when I talk about itching and sneezing, rhinorrhea, congestion, and edema, which has been caused by the irritation nerve ending, mucus production, vasodilatation, these are the symptoms what will present as allergic rhinitis. What happens? Histamine release, acetylcholine release. What does histamine do? It causes itching, it causes sneezing, it causes rhinorrhea. What does acetylcholine do? It stimulates the glandular secretion, and all of them mix and match together to lead to the situation which leads to the symptoms of the allergic rhinitis. So how do you diagnose it? First of all is history. You must take a detailed history, what causes it. Quite a few of the times you can find out what the allergen is. If it still is not be there, we have a lot of battery of tests, which Dr. Rajkumar has been conducting courses on how to identify the various tests, is what we need to do. Family history, personal history of other long-standing recurrent colds, sinuses, infections, everything, all these things would help me to solve the jigsaw puzzle. So how does the nasal allergy affect my body? Allergic rhinitis causes asthma, it can cause cold, it can cause sinus infections, it can cause nasal it can cause ear infections, it can cause simple colds. So basically, it can cause many other things. And when it affects my nasopharynx, my adenoid hypertrophy could occur, nasal polyps could occur, sinusitis, laryngitis, viral infections, otitis media, tubal dysfunctions. So all these things could cause the problem which I would be faced with. So allergic symptoms which are there, and not only limited to me, it is limited to even my pet dog or even pets or any other sapien which is there. So what does it cause? Nasal congestion, rhinorrhea, pruritus. We already talked about a little bit in the last slide why it is caused, what are the mediators which are causing this, and the symptoms which can produce. But not only the nose symptoms, it can also produce tearing from my eye, epiphora. It can cause itching in the palate. It can cause itching in the ear. It can cause the post-nasal drip. It can cause anosmia. So all these things can be caused by allergic rhinitis symptoms. Not only the symptom local, it could also cause psychosocial and cognitive disorders. Fatigue, depression, irritability, anxiety, sleep disturbance, poor concentration, reduced productivity, impaired learning, decision-making. Imagine your nose is blocked at night. Imagine you're sneezing at night and you're awake at night. So what happens? Next time you're driving a car, bang, the car goes. What else? You're sleepy, you're irritable, work output. You get trouble with your boss shouts at you. What's this? You are sleeping the whole day. The problem is not with that. The problem is that I could not sleep at night. Why could I not sleep at night? I had allergy, I had my nasal blockage, I had sneezing, I had so many issues. So all these things form a part of my disease process, my symptom process, which could lead to my physical inactivity. Sore throat. Then I could have mouth breathing. I could have chronic cough. Comorbidities along with that. It is not only my nasal issues which come. Now comes my wheeze, my asthma, sinusitis, otitis media. You see, allergic rhinitis frequently occurs with asthma and atopic dermatitis. The relationship is there. We need to prove and go further on that relationship. Sneeze and the wheeze are married. We need to see to it that the marriage continues in a much more comfortable manner so that it makes life more simpler. It is there. It is there to continue. How we make it more comfortable is for you and me to decide. Adenoid hypertrophy, lower respiratory tract, bronchial infections, otitis media, respiratory. So all these things are a part of my comorbidities which could exist with allergic rhinitis. So diagnosis, history, physical examination. I can do skin prick testing, nasal smears, for which we have specialty clinics which are existing. I think Patel Chest runs one of the most finest clinics which are there. If you look at it, Dr. Rajkumar conducts 2 courses every year on this issue, which I think he's doing a yeoman's job in taking the tests all across the country and outside the country to help our colleagues to try to diagnose and manage this problem of allergy. You manage one problem, so many other problems get sorted out along with that. So when you look at it, we could have viral, we could have bacterial as comorbidities, seasonal, perennial, chronic, so many, all these things we have said. The non-allergic issues, we have to differentiate between the two. Gustatory, vasomotor rhinitis, non-allergic rhinitis, rhinitis medicamentosa, emotional, neoplasm, trauma, all these things could mimic the whole situation. It's something like, I have so many times, how many people have diagnosed bronchial asthma, put them on steroids, put them on inhalation, and what turns out? It was a foreign body in the bronchus. So this things of differential diagnosis and bringing about diagnosis of pinpointing it what the cause is very important, that we are dealing with bronchial asthma, we are dealing with allergic rhinitis, and we should not make a mistake at times, a gross mistake which happens so many times. It has happened in our emergency services. The patient has been treated for a bronchial asthma, the child is there, but the child had a foreign body inside. So diagnosing it properly and being aware, only then you can diagnose it properly if you are aware. So how do we identify the problem? Identify the cause, identify the treatment, identify the prospect, the preventive aspect. So once we do this, our thing becomes very simple. The question is, it's very difficult to identify the problem. It is difficult to identify the cause. Once you have identified the cause, treatment is also a challenge. And once you have found out the cause, prevention also becomes a challenge. So basically, management is a huge challenge. So we must know what to look for. If we find it, then we should prepare of how to manage it. So we need to look, analyze, treat, manage, prevent, approach. This should be our approach for managing allergic rhinitis and asthma. So when we look at the management options, what do we have? We have a pyramid. We have environmental control, we have drugs, we have immunotherapy. Depending on what, the dilemma is, what do we choose from? Where do we choose from? And this dilemma is what is depicted in this song. Which side should I go? Should I go for immunotherapy? Should I go for pharmacotherapy? What pharmacotherapy should I use? Should I go in for certain surgical procedures which may be available? What method to use? How do I prevent it? All these things come to my mind as and when we listen to this song. And this dilemma is something what you and me have to learn to solve. So what do we do? Let us look at it, the treatment options. Number 1 is avoidance, modifying the factors and patient education. So what do we do? The bed encasements, the bed covers, etc. What we look at it, impermeable bed covers. So whatever dust settles down on the bed covers should not infiltrate down onto my bed sheet on which I'm going to sleep at night. I should wash my bed sheets at a particular temperature so that it gets free of those issues. The question that comes is, do I really wash them at that 130 degrees Fahrenheit? I do not know. Dusting, vacuum cleaning, air conditioning, filters. Do we have air conditioners? No, most of our air conditioners are air coolers. We need to have HEPA filters. Those air conditioners are more expensive. Then humidity. The air conditioner is supposed to control the humidity also. How many of our air conditioners have those filters? How many of control humidity? That is what the difference is. So all these things would contribute to that. The question that comes is, what do I do over here? So I need to choose my environment. I need to explain to the patient how the medicines work. This would form the basic situation. Environmental controls. How do I do? Keep my closed. You know, the joke part of the whole thing is whenever pollution. So am I audible?
Yeah, there is some disturbance, and your slides have also not visible.
Now is it, now okay, I'll just share it again once more. Is it okay now?
I think there is some net problem at your end.
Is it better now, sir? Is it okay?
Not visible.
Not visible. Audio is there?
Yeah, your audio is there. Dr. Rajkumar's audio is not there. He's on mute.
Mute. Yeah, I'm not mute.
Yeah,
You have to share the slides. Yeah.
Is it audible now, sir? Is it visible?
No.
No, not. Yeah, is it okay now?
Yeah, no.
Okay. Okay.
Yeah. Please go ahead. Yeah.
Okay. So we are looking at the environment which are there. So I need to keep my windows closed, reduce my outdoor activity. But then where do my children go to play? Because they are around my outdoor activities, if not because of the pollutant, it's because of the environment. So where do I go? I get so happy that today my Delhi air is poor. I mean, what is there to be happy about? It was from very poor, it has come down to poor. When does it have a good day? Hardly anything we have on good days. So when do my children go out and play? And if they don't go out and play, where do they get the sensitization for all about? Maintain dust allergen-free environment. Kahan se leke aaunga main dust-free allergen environment? Use air conditioning, keep my pets outdoors, avoid smoke, strong odors. All these are easier said than done things, though they are practical things, but they need to be done. So what do I avoid? I avoid all these things. How? School, allergen sources, restaurant, outdoors, pets, dust, holidays abroad, food in the home. What do I do? All these areas are the ones which are really affected, and they create a problem for me of how do I manage it. Then comes my medication arsenal. I have a huge list of medicines which can be done. Antihistamines, decongestants, corticosteroids, cromolyn, ipratropium. All these things have a base somewhere or the other. And how do I manage them? Now let me look at the symptom relievers. We said we had certain symptoms which were there. So what are the symptom relievers? I could have first generation antihistamine, second generation, or topical antihistamine. Now when I look at first generation antihistamine, they're very good. They're very effective, but they have a problem of drowsiness and sleepiness which occurs the whole day. My second generation, slightly less effective, but non-sedating. Therefore, on a compromise basis, they are a very good option. Then come my topical antihistamines. Topical antihistamines were good at one time. The management of any disease is a very dynamic process. Today, I have something which is very effective. Tomorrow, the thing effectivity may not be there. Now, let us go for COVID. What happened in the COVID times? So many medicines came out. It is mandated to use this. There was black for ivermectin, and all these medicines started having available in the grey market at cost which were 10 times, 15 times. And at the end of the COVID epidemic, suddenly one fine day, somebody comes and says, oh, ivermectin did not have any role to play. So it is such a dynamic situation that things and the indications keep on changing. I need to have decongestants. So pseudoephedrine, phenylephrine, very good things, but then they cause cardiac issues. Anticholinergics, leukotriene modifiers. Now that leukotriene modifiers is something what we will just talk about. So we talk about antihistamines. Now, if antihistamines don't work, then I also need to add a little bit of systemic decongestant to my management because my nose needs to be cleared to make me more comfortable. So when it comes to intermittent allergic rhinitis episodes, the first line of treatment would be antihistamines, which would look after my sneezing, pruritus, my rhinitis symptoms, etc., rhinorrhea. If the nasal congestion is a middle symptom, I need to add an oral decongestant to my management. And then further it is, if I look at it, a combination of an antihistaminic and a decongestant control is better than an antihistamine alone. But there are certain issues which are involved. There are medical issues which are involved, and those need to be seen. So treatment, then I need to add steroids. Why? When? So if I add steroids, when do I add steroids? Prolonged symptoms. I need to add them to the antihistamine and decongestant regimen. I will need to reverse the persisting inflammation. Now, we need to understand one thing. Whether we talk about allergic rhinitis, asthma, somewhere down the line, they are inflammatory in nature. The basic pathology over there is inflammation. So the role of anti-inflammation over here is very important, and that is where the role of steroids comes into the picture. So steroid is, when I talk about steroids, when I talk about inhalational steroids, they form a backbone of management today. So will they prevent nasal priming? That is there. So how does it happen? When I add that, it reduces the inflammation, suppresses my neutrophil chemotaxis, mildly vasoconstrictive in nature. It reduces the intracellular edema. With the result, the edema part is reduced. Therefore, it reduces nasal blockage, pruritus, sneezing, and rhinorrhea. So I have a improvement in my situation. So why does it happen? Because it is the most potent single medication. Intranasal, it acts locally. My goal is what? Control symptoms with the lowest possible dose, achieve maximum symptomatic relief, most effective and started preemptively before the exposure. Now, this is where the issue comes. I normally tend to start the things once the process has started. Once the process has started, it is a cascade phenomena, so it may not be very effective once it has started. My therapeutic efficacy within 1 to 3 days, but maximum efficacy may take up to 3 weeks to start. So we need to be realistic in our approach and what we are going to tell the patient as to how it is going to take its effect. Don't expect a miracle. It will take some time for it to affect. That is why it needs to be started before the pollen season, and compliance is critical. Effects of nasal irritation, bleeding, etc. will be there. Well, local decongestants are good and bad both. We need to be careful in what we call as the rhinitis medicamentosa. That is because of the medicines, my nasal obstruction becomes much. I have antihistamines, which anticholinergics, not much part in sneezing, but rhinorrhea gets controlled. Corticosteroids, for sneezing, yes. For itching, yes. For rhinorrhea, yes. For congestion, yes. Decongestants, for congestion, yes. Mast cell stabilizer and anti-leukotrienes. Now, montelukast, etc., have a good role to play in a long-term preventive thing. But then it's a dynamic situation. Today, what medicine is there? Tomorrow, FDA issues certain other guidelines that you need to be careful. So I have all these issues, all these medicines which are there. They have side effects. If you see, a big list of side effects are there. But at times, suddenly the FDA will come out and issue a guideline regarding those medicines. So what may be a good medicine today may not be a good tomorrow, and vice versa. It is like desi ghee. Sometimes somebody says it's very nice to have desi ghee. Next day, sometimes, oh, you are having desi ghee, it's very bad, stop it at all. Go in for olive oil. Third day, sunflower oil. Fourth day, you are back to desi clarified butter and desi ghee. So things keep on changing dynamically. What is my limit for blood pressure? Is it 90 diastolic? Is it 95 diastolic? What is my safe limit for blood sugar? Is it 80 fasting or 90 fasting or 100 fasting? It would all depend upon a lot many things. But yes, a combination of my inhalational steroids, a combination of my anti-leukotrienes, my medicines like Montelukast, all the lastines, all these things will make in the long run a help for me. Immunotherapy. Now, this is, in my opinion, the future for management of allergy. Pharmacotherapy, if it is insufficiently controls the symptoms, then immunotherapy needs to be done. Appropriate avoidance measures, they fail, immunotherapy needs to be considered. History for at least 2 seasons or 6 months, this needs to be considered. Positive skin tests, we need to correlate and manage it. Immunotherapy needs to be debated, what needs to be looked at, what needs to be trained for. And that again, I feel one of the yeoman services done in the country are the respiratory allergy workshops, which are again being conducted by Patel Chest and other institutes. But I think these workshops, if I may ask Dr. Rajkumar, how many times, twice a year, and how many years has this workshop been going? At least I've been going to his workshop for more than the last 10 years now. And the workshop is packed to the capacity while these hands-on training is there. Less focus on lectures, more focus on hands-on training. That is what workshops actually should be all about. So treatment of the comorbidities. It is not only the primary treatment that needs to be done, we also need to manage the comorbidities. Like we said, nasal polyps may be there, ear issues may be there, sinusitis, turbinate size reduction, nasal airway surgery, and then above all, manage the part where it goes to, that is the asthma part. So fast acting to control the early phase, long-term acting to control the later phase, and the compliance dosage should be such once a day or twice a day. But if you're going to say that you have to take it 4 hourly, 6 hourly, nobody's going to take it. The compliance rate is going to be very low. Less side effects, should not be sleepy, drowsiness, driving action, psychological issues could happen, depression could happen with certain medicines. So we need to be careful about those. And it should be able to manage all the symptoms and a good intranasal administration. The important point over here is intranasal administration, or whether I'm going to give inhalants for my asthma. The method of delivery of the drug is very important. How am I going to use the inhaler? That is very important and needs to be taught. So when to refer? You refer it when you think that the reference is required. So if you think you cannot manage it, the referral needs to be done to the specialist, ENT surgeon, ENT specialist, or the chest specialist, pulmonary specialist, physician. All these areas need to be looked at if I cannot manage. When the patient does not respond to the indicated treatment, when the patient has certain complications which happen due to the allergic disease, it is time to learn to refer and not burn your hands. One needs to be very careful today. In today's time of ethics in medicine, we need to be careful what we are managing, how we are managing, when to manage, and more importantly, when not to manage. When to refer and when not to refer is an important decision which every physician in the country must know. It should be worked as a teamwork. Who makes up this team? An ENT surgeon, pulmonologist, general physician, allergologist, dermatologist, immunologist, pharmacologist, you name that branch, and he has to be involved in that. And who are all these team members? If you see the finger pointing, it is pointing at all of us, at you and me. So if I will close down with this one small song over here. This is a song from an epic movie, Mughal Azam. So this song was from a movie, Mughal Azam, which K. Asif produced as one of the most beautiful epics. Nothing was left deficient in this movie, including the story. This lady, Madhubala, who enacted the role of a dancer, wanted to be Ek Raat Ki Malika. And Zille-Lahi Akbar did not want her to be, and she wanted to marry the Sahibzada over there. And after great concoctions, she managed, Akbar gave her the permission, Ek Raat Ki Malika Tum Ban Jao. So she had got what she really wanted. And then when she got what she wanted, everything was very nice. The movie was produced. Anarkali became a hit. Madhubala became a hit and this movie became a hit. If anybody was asked, do you want to change the movie? The answer would have been no. It is absolutely perfect. Would anybody ever ask, Madhubala, do you want to change your role? No. If anybody would ask, does Anarkali want a change in her lifestyle? No, because everybody has got what everybody wanted. So I'll again close with this thing. इंसान ने वक्त से पूछा मैं बार बार क्यों हार जाता हूं. वक्त ने कहा धूप हो या छाओ, काली रात अच्छे दिन हो या बुरे. That movie which was there, nobody wants to change it. But what happened? What happened to Anarkali? When Anarkali could change, and you and me don't want to change, things will never change. So let us be like Anarkali. Even though we have the best of the knowledge today, let us change this knowledge to a better knowledge tomorrow so that we can go ahead and leave our Zillahis, this thing, and enter into the realm of Anarkali and go to the disco. If we manage the sneeze, I am sure we'll be able to manage the wheeze. Otherwise, both of them are going to end up in a huge divorce and big tragedies. Thank you so much for this opportunity, for having given me this opportunity. Thank you, Dr. Rajkumar. Thank you, the organizers, for letting me be over here.
Thank you, sir. Thank you so much for excellent lecture. And really, we enjoyed. I think the participants might have enjoyed this lecture. And as usual, this lecture was super. So, sir, with this, I have some questions which has come to my chat box, and I'll be putting across to you these questions. And
yes, sir.
Yeah. So one of the question which has come, because we know that the pharmacotherapy also are given, and depending upon the pharmacotherapy, which generation we are giving, starting from the your nasal decongestant to the oral corticosteroids. The question is how the bilastine works in allergic rhinitis, and for how long this bilastine and the montelukast combination can be also given.
So let me come down. Like I said, it's a very dynamically changing word. Whether I look at azilastine, bilastine, whether I look at montelukast, I look at first generation, second generation antihistamines. So all of them have evolved over a period of time, and they were very good in their own period. Now, if I take an example, chlorpheniramine as a first generation antihistamine. It was an excellent thing while it existed. But then people were having drowsiness. So that coaxed us to go into a second generation, third generation antihistamines. We came down to cetirizine, azilastine, bilastine. So what happens over there? The drowsiness is less, the side effects are less. Once the side effects are less, the acceptability becomes more. Secondly, a problem which I'm looking at is not a short-term problem. I'm looking at it over a perennial, because if you go back to the slide, we could have perennial, we could have a short-term thing. So if I'm going to have a problem which is perennial or which is a long-standing problem, I need to have medicines which can be given over a longer period of time. My first generation antihistamines, I really could not give them over a long period of time. Let me look at systemic steroids. They're very effective, but I cannot give them over a long period of time. So my nasal steroids came into the picture. My azilastine, my cetirizine, my bilastine, all these have come into the picture. Now they have less side effects, they have less drowsiness, and they can be used for a longer period of time. So with time, dynamically today, they are acceptable norms. Tomorrow, I do not know. Like yesterday, the FDA has parked out certain issues that we need to be careful with regard to the psychological issues which comes across with certain medicines. So all these things, all these medicines also have their side effects. So there is nothing known as a free lunch in the universe. I have to rob Peter to pay Piper. Somewhere I have to draw a thin line as to whether my cause and effects are very well balanced, and that is what I need to look over here. So today, if I look at bilastine, if I look at montelukast, they are good medicines to have. Tomorrow, we may have better medicines. We may have further derivatives from these medicines to carry forward.
Okay, so it's all basically changing and everything. And another question which has come, why there is a body itching in the allergy, and another is why allergic rhinitis is very common in the early childhood.
So early childhood, in the sense, if I leave out the first 3 to 4 years, that is the time when it is not very common. It is common after 4 years or 3 years or 4 years of age, because by that time my sensitization has occurred, my first exposure, my second exposure. Also, today's time, my children are not exposed to the allergens because they are in a protective atmosphere. I don't permit them to go out and play. Now, if I look at, let us say there is somebody in the Dhobis children who are just ironing the whole day in my street, which is behind my house. They are playing in the dust. They are playing over there. So they are much more healthy than my children who have not been even had the first exposure. So that is why the protective atmosphere has led to more problems at times. It's always becoming a catch-22 situation. I protect my child from a bad environment, but I put my child into an environment which makes him more prone to certain other issues. So it's a very difficult situation to handle today. But yes, the first exposure, the allergic rhinitis would be present not in infants, not in small children, but after the age of 4 years. Until the time I'm about 25, 30, 40, my peak occurs over there. It all depends upon what my exposure level is and how much exposure I'm getting across. You see the US, sir, they have the carrot weed, they spread across the whole of the central part of the country. And that is when the ragweed allergy takes over. And there are medical emergencies, just like we had COVID center set up. They had ragweed center set up over there to manage this allergy. The same thing, Bangalore is supposed to be a very nice city. But today, carrot weed and ragweed has been a lot of Parthenium plants are being found in Bangalore. So the allergic problems are going to go much higher over there. Earlier, my breeze used to blow. It used to carry my pollutants out. Today, because of my environment situation, my breeze is not blowing. The water content, humidity level is there. So all my pollutants get settled to a level which is at ground level and my nose level. So I'm getting in a further inhalation increase in the thing. So a multitude of factors play a role in having my presence of the allergic symptoms. So it is a widespread disease, allergic rhinitis, spread across all ages, but more between 4, but peaking at about second decade, third decade, then going down as the period comes. And a lot of it depends upon my immunological status. What is my immunological status? My vitamin D status. So all these things mix and match and make the situation which comes across in presenting the allergic rhinitis.
Sir, another question was, what is the relation between the skin allergy and the allergic rhinitis? Is there any relation with this?
The principles for allergy remain the same, sir. The principles for any allergy in the body will remain the same. The target where it is manifests itself, whether it is the digestive tract, whether it is my aerotac, whether it is my nasal tract, my aerodigestive tract. So all these things make a difference. All these things are common. The principles remain the same. The manifestation may be different.
And what is the role of the family history in case of the allergic rhinitis? Another question was, you have already put the box, giant box about the genetics and everything. So the question the participants wanted to know that the family history of rhinitis is important.
If both my parents are non-allergic, I have a lesser chance of allergy. If both my parents are having allergic predominance, I have almost a 70% chance of having an allergy in some form or the other. So the genetics would again be family history related and my genetic mutation which could occur over a period of time. So both these things combine together and it manifests itself in the form of an allergy, sir.
Yeah. So another question was a lot of people give the different kinds of the antihistaminics, maybe if you call in a broader anti-allergic medicines. So according to you, for the participants, which will be the best drug which can be given in the allergic rhinitis?
A very, very difficult question, sir.
And there are many combinations, 2, 3, even 4 combinations are there the people are giving. So according to you, for the masses to go across the participants, so what will be the drug of choice in case of the allergic rhinitis?
One must know the pharmacology of each drug that you are going to prescribe. So that is very important. Like yesterday, the government of India has come out, the day before yesterday has come out with a directive for all doctors. If you have to prescribe antibiotics, you must put the indication of antibiotics on the prescription. So now the onus will be shifting to the doctor for prescription and why is he prescribing the medicine. So the knowledge about the pharmacology of the medicine is very important. You give me a choice, cost factor, chlorpheniramine. 1 paise, 2 paise, 3 paise a tablet. Problem is, it is difficult to be handled by the patient. Let us come down to the next group of, let us say, cetirizine over here. Now causes less drowsiness, effective, good medicine. Add to it montelukast, good medicine. Beta, if I look at bilastine, good medicine. So like I said, you need to know the pharmacology. You need to mix and match the combination. That is where your experience is going to come in. You know, patient does not come to you as a primary thing. He has been to 10 doctors before he comes to a specialist. And that is a time when whatever medicine you prescribe, he says, I have taken this, I have taken this, I have taken this. So it becomes a very difficult thing for you. So you need to mix and match the things and know the pharmacology of the agent, whatever you are going to give, sir.
Another
But if you ask me, my first choice would be an if it does not handle with a simple second, third generation anti-histamine, time, when, where, how that needs to be decided.
Yeah. Hello. Hello.
Yes, sir.
Hello. Yeah. No, actually, there are some disturbance. So if you given a choice, what will be your best choice? Can you repeat it? Yeah.
Sir, if you give me a choice, I would start with a simple thing like maybe cetirizine. If it does not work, I may add an intranasal steroid. I may add montelukast to it. I may add bilastine. You know, I have a big variety over there. I need to mix and match because the timing is important. When am I going to start it? When did the symptoms start? And how long am I going to look at it? So what type of allergic rhinitis I have, that would need to be seen perennial or seasonal or whatever it is. So I would need to start it before the season starts. So a good history has to be taken. So what point of time I'm going to start? The urgent part is I need to stop the sneezes. So there I need to take a short-term antihistamine. But on a long-term basis, I need to see something which is different and mix and match my medicines over there.
Okay, so short answers, basically, the last three questions are, what are the tests to be done for the allergic rhinitis?
Well, sir, you are the best judge for that because the challenge test, the skin allergy test, the skin sensitization, all these tests are important. For that, I think I'll leave the ball to your court as to how to go about and doing those testing. You know, when I'm going to do the test, my original statement which comes is, be allergic to anything under the sun. Am I audible now, sir? Hello?
Yeah, this is okay now. Yeah.
So
yeah.
What the types of allergens which I have for testing are not infinite. My allergens are infinite. So what I do is I collect as many allergens as possible, put them in a blender, blend it, and then give a taste to that and see what it. So you may be I can test groups of allergens and then desensitize to that. But I think for that, you are the best judge how to go about finding out the allergen and desensitizing the individual.
Okay, so I'll just 30 seconds. I will just tell what we do with allergic rhinitis and all the patient basically when we give the pharmacotherapy and all. And if it is need of going for the allergy testing, we do the allergy. History is very important. According to history, you try to have the allergens with you and then do the allergy testing. And if the allergy testing is positive, it's just a sensitization. So you correlate with the history of the patient, and after that you find out the if it is correlating with the history, then it is a positive for the allergy. And then if it is avoidable, then you can avoid it. If it is not, then immunotherapy can be given. And the concept of the immunotherapy is slowly increase the antigen quantity, then the concentration and the duration. So I think in this way we go ahead with that. And there was actually question on the immunotherapy, and I think short answer what I have given. The last question, sir, what are the factors affects allergy?
Yes, sir. So I think a few things need to be brought over here. Number one is the gastroesophageal reflux disease. Now that sensitizes the mucous membrane for infiltration by the pollutants much more. So here comes again the role of the protein pump inhibitors, like what we give, that can be pantoprazole, etc., can be given along with that, because that would help to reduce my GERD and reduce the penetration of my allergens over there. Another thing what we need to look at is just supportive measures is to keep my mucous membrane moist. What happens is when I keep my mucous membrane moist, because whatever medicines I'm giving, whether I'm giving steroids or I'm giving antihistamine, my mucous membrane also will dry up. When mucous membrane dries up, my cilia also stop working. So as long as I keep my mucous membrane dry, my cilia is working, which act as a housekeeping. Remember we said they're good housekeeper. So it keeps on sweeping the mucous membrane clean and keeps on reducing the dose of my pollutants over there. So saline inhalations, steam inhalations, saline sprays, proton pump inhibitors, all these when added to that also help my management in the long run, sir.
Okay, so another last question is, like many times what we see in case of the allergic rhinitis, the patients do actually have some cough, some a bit of cough is there also, maybe because of the postnasal drip and also. But when we do the pulmonary function test, there are mild obstructions. So also, how to go ahead? Can you give a comment on that?
Sir, the cough which you are looking at, again, like I said, is due to the GERD which happens, sir. My lifestyle management, GERD leads to an acid reflux, which leads to irritation in my throat at the back. And that happens more in the morning because at night my regurgitation has happened and my mucous membrane in the throat is irritated. And that is why I have irritable throat and the cough which happens. So they may be totally not interrelated with each other. The pulmonary function test may be a different manifestation in itself, whereas a cough may be a different manifestation in itself. So allergic cough is one part, but if the issue goes down to my lower respiratory tract, that is when my pulmonary function tests start deteriorating, sir. आप म्यूट हैं सर, आप अनम्यूट कर लीजिएगा सर.
Okay, so yeah, thank you so much, sir. And I think I am not able to find out any more questions on the chat box. And another, maybe the last, that for the benefit of the audience, is there any role of the lifestyle in the prevention of allergic rhinitis?
Yes, sir. सर हिंदी में कहावत है, ना रहेगा बांस ना बजेगी बांसुरी. So lifestyle management is very simple. Learn to avoid places which are highly pollutants. Learn to avoid not going for exercise early in the morning. Learn to be in a space suit and get yourself transported to the moon or the Mars where there will not be any pollutants over there, Indian earth pollutant that we have over there. But lifestyle management does make a difference of how much work you are going to do, where you are going to do the work. My workplace environment, I need to improve it. I need to have a desensitization of my body over there so that my resistance increases. Vitamin D is playing a good role today, sir. So all these things with lifestyle management, also my GERD needs to be protected by lifestyle management, and that is what is going to make the difference, sir.
Okay. So another question which has come, I think you have already answered, but still the participants are asking. Family history, I think there was some problem at that time. So what is the role of the family history in rhinitis or genetics in rhinitis?
Yeah. Sir, if I look at it, if my no parent is allergic, the chance of me having allergy is less than 10%. But if my both parents are allergic, the chance of me having allergic rhinitis is something like 70%. So one parent, both parents, no parent. If you analyze these, it clearly shows that there is a family history, there is a genetic predominance. What happens tomorrow, my certain genes may be mutated. And once mutation happens, the entire picture changes. So I may have a situation. I'm extremely important in do I have asthma in the family, sir?
Okay, I think we have already completed all the questions which was there in the chat box, and of course the time slot which was given for 1 hour, we have already finished that time slot, and I am thankful to Dr. Achal Gulati sir. Beautifully, the presentation was there. all the questions which has been taken care by you, sir. And we always, Indian College of Allergy, Asthma and Immunology is always admire you for your help for any kind of the programs which we do at a different level. And with that, I thank the organizers, especially Dr. Anup Agrawal, and of course our own Indian College of Allergy, Asthma and Immunology, which has given us the chance to come on the webinar for this program. And with that, I will request the President, Dr. Behra, if he's there. Dr. Behra?
Yes,
Dr.
yes.
Behra? So I request Dr. Behra to give a concluding remark, and then after that we'll close the session. Dr. Behra, sir.
Actually, you should compare.
Okay, thank you, Dr. Rajkumar and Dr. Gulati. I should say it is an excellent and outstanding talk, as well as the moderation. So I'm sure all of us are benefited, and we had some awareness. And thank you, Dr. Gulati, for helping us, and also Dr. Agrawal for sponsoring this event. So I thank all of you. Thank you.
Yes, go to the mic.
I also take this opportunity, sir, to thank everybody. Thank Dr. Digambar Behra, thank Dr. Rajkumar, thank Dr. M.K. Agrawal, the entire organizers over here, and the organizers, Dr. Anupam, for giving me this opportunity of expressing myself over here.
Total pneumonia case of sample.
So thank everyone, and on behalf of Indian College of Allergy, Asthma and Immunology, and of course organizer Dr. Anupam Agrawal, I am with all due permission from the President, Indian College of Allergy, Asthma and Immunology, I close this session, and thank you so much. The people can log out. Thank you so much. Thank you. Thank you so much. Thank you. Thank you.